Medications for opioid use disorders in correctional settings. Shifting the paradigm, creating a balanced correctional and rehabilitative approach. The Opioid Response Network is funded by SAMHSA to provide resources and technical assistance needed locally to address the opioid crisis. This video is part of a series to provide guidance on the implementation of medications for opioid use disorder in correctional facilities. Leading corrections and behavioral health experts present information on topics such as the use of medication, models of delivery, diversion, and linkages to care and community support. Debra Pinals and Tom Lincoln discuss comprehensive OUD treatment in correctional settings.
Hi, I am Dr. Debra Pinals. I work for the University of Michigan, where I'm a clinical professor of psychiatry, and I run the program in psychiatry, law, and ethics. But another big part of my job through the University of Michigan is serving as the medical director for behavioral health and forensic programs in the Michigan Department of Health and Human Services. And so what that means is I'm a psychiatrist, I'm addiction medicine certified, and I do, in accordance with our statute in the law of the state of Michigan, I advise on matters related to mental health to the Department of Health and Human Services at the state level, as well as to all other departments, including the Department of Corrections, and doing a lot of work with the jails. So it's a great privilege for me. I've had the good fortune of I am a card-carrying member of the AAAP, and I love working with Catherine and the crew at AAAP and all the great work that they're doing to help us do better by this opioid crisis that we're dealing with. Let me just say, in terms of disclosures, I don't have any particular conflicts of interest pertaining to this lecture. I do consult to other jurisdictions and other organizations, and I'm glad to see my co-presenter is here, and he will jump in when it's his turn. So what do I want to say about my years of working in this correctional interface that gives me any ounce of credibility to be standing in front of you who are living and breathing the correctional interface and thinking about medications for opioid use disorder? So I have worked as an attending psychiatrist in jails and in prisons in my career. I have consulted in litigation matters related to prison and jail care. I'm not sure I mentioned, I'm also a forensic psychiatrist. I've been a consultant to correctional systems, and I've developed programs that work at the interface, especially at the reentry interface. And I've been fortunate, and some of my colleagues, Beth Boyd from the Michigan Department of Corrections is right here, who's been one of our champions in Michigan. I see some friendly faces from Massachusetts, June Binney in the back, working at the interface of reentry services. The other thing that I just want to mention, too, is that in some of my other hats that I've worn over time, I also manage clinical services for specialty courts, and I work a lot with courts. And so it's really important as we think about the people that I've worked with. I see some other friends in the crowd, too, that I haven't seen in a while. The people that I've worked with, we want to think about these people as people with medical conditions that are moving in and out of systems. And the more we can think about them as people moving in and out of systems but having healthcare needs that really don't change. I mean, of course, conditions can change, but essentially their needs don't change regardless of the walls that get put around them. So I use this a lot in my examples, like diabetes care. If somebody needs insulin for their diabetes, they need it whether they're in jail or prison or the community. That's just what they need. And that's part of the big cultural shift in terms of thinking about MAT and MOUD in correctional settings. We're really talking about a culture shift. So this is the administrative group that's getting together to sort of think about and scratch their heads as leaders and the people that are going to be developing the policies and implementing the policies and hiring the staff and issuing the RFPs to get the contracted providers to do the work that we need to do and make the right linkages. I mean, there are many, many pieces that makes this complicated as an administrator, but there's many things also pushing us in the direction for better care. First of all, we have the opioid crisis. That goes without saying. That's why we're here. The federal government has funded this initiative and has put a lot of money into this, as have local jurisdictions, philanthropies, and the like. There's also an increasing recognition that the population of people moving in and out of the criminal justice system are at some of the highest risk for mortality. We're learning more about other populations. We're learning about how to parse those out from a socio-demographic perspective, racial and ethnic disparities that might be part of the mix, and a whole host of other things. And we could also argue that the same people that are at risk of death upon release or in these transitions of care, there's a sort of a chicken and egg, which came first. The criminal justice system actually has pivoted a lot of its work in offender management on this paradigm of risk-need responsivity, which was essentially developed out of research by Andrews and Bonta back in the 90s, looking at who in the substance use community is going to be at high risk of criminal recidivism. So it's sort of interesting now that we're also thinking about the people that are at high risk of criminal recidivism being at high risk for bad outcomes related to opioid use disorder. And of course, we're talking about opioid use disorder, but as the data is unfolding every day, we're learning more about the methamphetamine crisis that's coming into the fold and how to manage that, which doesn't come with medications kind of at the ready, and a whole host of other things. There's the silent crisis about alcohol use disorder that doesn't really get talked about as much, but is really another issue that we see, and we're doing a lot of work with kids and services around fetal alcohol syndrome and the like. But there's lots of things happening as we look at this high-risk population of people traveling in and out of these justice settings. We've got scientific advances in treatment. We wouldn't be here today if there weren't those scientific advances telling us that we actually have medicines that treat these diseases. And so we can thank the scientists for helping to develop those. There's legal cases. There's pressure on correctional systems, usually using something an Americans with Disabilities Act argument, or perhaps a constitutional argument about the right to access health care that's equivalent to what's available in the community for people that are held in carceral settings. And then, of course, there's funding opportunities, and where there's funding opportunities to do things better, we often do things better. The thing is we have to really think about is what are the sustainable planning efforts that need to happen, because these funding opportunities may go at some point as the opioid crisis hopefully gets better, but we will still, this will be the theory is we will all be part of changing the entire culture of how correctional care works with regard to at least opioid use disorder. So your job in this workshop is to get your wheels turning about what you're going to do in your own systems to take things home and make it better. So one of the things that we've been doing in Michigan, and I'll just pull from some of these examples, is we worked in partnership with our Sheriff's Association as well as our Department of Corrections to do a survey of there's 81 jails in the state of Michigan. We've done a survey to look at their readiness, their accessibility to MAT. Why is this important? Number one, we want to know for the people coming into the jail, are they going to be ready to help treat the conditions that people may already have had access to treatment for? Or are they going to be ready to start people on new treatments if they hadn't been identified before? We also know that people travel from jails to prison. That's a pathway. So the MDOC wants to know, because they want to know what's happening as they start receiving people and be at the ready. And then, of course, we want to know because people are moving out back into the community. Most people who are incarcerated will be moving back into the community. And we, at the Department of Health and Human Services, where we have Medicaid funding for most of the people coming out of the jails and prisons, need to make sure we have a provider network that's as ready as the correctional provider network, so we have seamless services. So we're doing a survey, and you might want to think about that. And what we're seeing in our survey is that our prisons are starting, the jails are starting. There's some that are not ready and not thinking about starting. So it's almost like the stages of change in addictions, like the motivation to get ready and take this on is sort of an ironic parallel to the recovery process. We have to have our systems be ready as well. So how do we get all the systems ready? And there is a lot that needs to be done with this, because we are talking about a culture shift. We're talking about a culture shift for the people that are suffering from opioid use disorder, who for many, many years we've all been taught that abstinence-based care is the best way to kick a habit. That's just not the thinking now, and so we have to get out, and that it's not a weakness to need a medication. So the people that are being served, the correctional officers, the administrators, the providers, everyone's in this culture shift kind of all at the same time. So one question I have for you, and we'll have discussion, is how ready is your system? So are full medication options available? Are prescribers able to prescribe or access all those medications? Are all 3 of the FDA-approved medications available for both initiation and continuation? Are policies and procedures in place to help facilitate these medications, as well as whatever other supports in the MAT framework are necessary to sustain recovery? Are staff appropriately trained to help facilitate this? You can put all the policies in place, you can open your med shelf and have all your medicines, but if your staff aren't buying into it and they're not ready, it's not going to happen. Are linkages established, again, both for people entering and leaving to decrease risk of relapse and overdose? And I would say not just linkages, but smart linkages. Culturally appropriate linkages, culturally sensitive linkages, people who can really talk to people, because there is one thing about medicine, there's another thing about that human interaction and helping people understand which medicine is right for them, why medicines may not have worked for them in the past, really dialoguing with them to help them provide the informed consent and be ready to start the medicine. And you will have some people who aren't going to be ready to start the medicine, so working with that as well, the rolling with resistance kind of thing, where you're also moving towards getting people ready when they're ready to be ready for this type of medication. So for example, in this one, you have an administrative interest, but your implementation has not yet started. How many of you would say that your facility fits into that category? You have interest by your administration in starting to deliver MOUD, but the implementation has not yet started. Raise your hand if you're at that level. So we have a few people. Okay, so for example, I just use this. You have a local jail. The average daily population is 600. The prescribers at the facility are unfamiliar with how to prescribe for persons with OUD other than traditional detox services. That's what they know, so you got some providers you got to train. The sheriff recently gained access to naloxone kits, so there's an interest in passing out naloxone kits, but not the full array of what goes with that in terms of thinking about the medicines. And you have interested leadership who've come to a conference like this. That's a good step forward, but it's not quite where you need to be. Example 2, partial implementation. How many of you work in a facility, again, let's just take an average, you could be bigger or smaller, it doesn't matter, where your average daily population is 600. You began having naltrexone injectable available in 2019. You've had, for many years, a methadone program for your pregnant inmates. You had an arrangement for your pregnant inmates with a local community provider. And now you're looking at trying to have your providers prescribe buprenorphine when it's needed, and you're starting staff training. How many of you are somewhere in that ballpark? You can put your hand up as high or as low as you want.
It's not all the way, but it's in between example 1 and 2.
Okay, fair enough. And then, now I only saw a few hands go up in 1 and 2, so I'm very curious. That means that everybody else is going to be in example 3, because I only have 3 examples. And I'm guessing that's not really going to happen. Here you have a prison population of 1,100. All intakes are screened for opioid use disorder when they come in. And they're also screened for other substance use disorders and mental illness, and they're assessed for chronic disease, Hep C, HIV, and others. Some individuals who are transferred from jails are already receiving, because your local jails are all in stage 3, and they're already providing MOUD, so people are coming in on methadone or buprenorphine, and you're ready to prescribe those medicines seamlessly. Your nurses, your prescribers, your security have all been trained. Sanctions, another part that might be part of full implementation, sanctions for misuse are managed through specialized considerations of illness management, not as sanctions and typical diversions have historically been managed. They're managed through perhaps something that looks like a drug court model, or they're managed through some alternative sanction process where you're understanding the nature of addiction and the need to re-engage, re-immerse people in that treatment. The individual is maintained and initiated on proper medications at proper doses, and the linkages are established for release to community providers. The parole staff, both institutional parole and field officers, are very well trained and well versed in OUD. You have policies that says people will not be violated if they have an active prescription for OUD, which the Michigan Department of Corrections boldly took on in writing, which is fantastic, so that we could train the staff that they weren't going to be getting sanctions if people had a valid prescription. And you're giving out naloxone kits both within your institution and upon release. How many of you are at full implementation? Okay, so we actually have a few of you in the room. That's amazing that we have that. And I would say that all of those would be necessary component parts to full implementation to think about, if you're really going to be thinking about how this works. So for example, screening tools that are out there, the RODS is one that's been written up in the literature as one tool. It's a brief measure. It can be used by non-clinical staff that ask simple questions. There's other rapid screens SAMHSA puts out in their TIP guidelines. And then of course there's some guidelines for screening for co-occurring conditions. That could also be implemented that you could think about, and screenings typically, just like in all medical services, route people to further assessment. Again, in terms of your implementation, the handoffs from the community or from the jails, initiation and continuation. What do you do when a patient declines the medications? How do you not just drop it and move on, but re-engage the patient at appropriate times, or the person? Do you have sufficiency of prescribers? Staff readiness and training, again, overdose prevention, both within the facilities and outside for what's going to happen when they're released, and then not forgetting co-occurring mental health conditions, which often coexist. And I'm not even talking about trauma, although that's another factor that we could spend an entire more than 3 days talking about trauma and the role of trauma in these populations. So you've got clinical service providers as administrators. You got to think about who's going to provide these. You might have a mental health contract, a substance use contract, and a medical contract. And sometimes never the three shall talk. Sometimes they do talk. Sometimes you have one contract that's supposed to do whole health care, like a health home within corrections. So how that is crafted, how the administrators write those RFPs for those contracts to ensure that there's cross-communication amongst those specialists, just like if I go see a primary care provider in the community and my primary care provider calls my psychiatrist, and everything is supposed to be aligned. Counseling, what type of counseling is available, how does information get shared, and then where's staff and security assistance when they need it. And then you have security considerations. Okay, what about diversion? How do you protect against diversion? These are medicines, some of them, are medicines that have diversion potential, misuse potential, so you have to protect against that without making the medications so impossible to access or so unappealing to access or so stigmatizing to access that people don't want to access them. So how do we think about that? What do we do about infractions in a correctional setting? What is considered an infraction and what is considered a cry for help? Now, when I say this to the security part of this presentation, people will certainly see me as a bleeding heart liberal. I understand that. But there are issues that we need to think about, just like we're trying to think about in the community. That's why drug courts came about, was the recognition is we can't incarcerate our way out of this drug problem. Let's try and think more creatively about how we're going to deal with quote unquote bad behavior or behavior that we don't like. Well, sometimes that behavior is cravings. And so that shouldn't, how does that work? Sometimes it's an infraction that warrants an infraction. And that, the correctional facility still has to be a correctional facility. So how do you balance all of those kind of tensions that do exist? So again, discipline and alternative pathways to discipline. Again, the attitudes and participation, the policies, the overdose prevention, staff support and well-being is another thing. I have managed services and you hear staff saying, none of this works anyway. Why are we bothering? There's a sense of learned helplessness. And I try to remind people that when you're working in high-risk environments, you are seeing the people for whom this hasn't worked. So you're seeing a higher percentage of the failures of treatment than you would probably out in the community in other types of settings. Although we do know that opioid use disorder is a chronic condition, and it takes a long time for people to gain their footing in their recovery. However, it's very difficult work. I mean, I do case conferences in our reentry program. I'm removed. I'm not on the day-to-day in the streets working with people, trying to get into the correctional facility and not having the access to the room that you need when you need it, when you have a tight schedule, and all the things that can stress people out in their day as they're trying to do their job. So somehow I think that part of the training of your MOUD program has to be how do we take care of staff in this regard too. And then finally I want to just talk, well, not finally, I have two other points I want to talk about, which is that community connection, reentry planning. There is a guideline called APIC, which is Assess, Plan, Identify, Coordinate, that talks about, that SAMHSA has promulgated for years. CSG has been part of this, but it's basically a guideline to think about what are the steps that are needed for reentry planning. We, unfortunately, in some of our services where we have a system, we use this model called Mission, and we provide wraparound supports to people, returning citizens coming out of the prison, and now we're moving into jails. We have taken some of our tragic outcomes and turned them into lessons learned. We're developing checklists based on the APIC model to make sure that all the things that we thought were being done are actually being done, because there are so many steps in this warm handoff that are necessary. Then we've got this issue of Medicaid. Medicaid is a very complex thing. So about, I'd say a decade ago, the big buzz around the country was make sure everybody's suspended and not terminated from Medicaid, because that way when they're suspended, they don't have to re-up and reapply, and they can just get turned back on. Well, what many states are realizing is that suspension of Medicaid is necessary but not sufficient for seamless access to care in the community. And partly because Medicaid is complex. There's often managed Medicaid. There's different plans. There's different choices. What people get upon release may not be the Medicaid plan that they sign up for within 30 days. And so the question is, what are your pathways, not just to getting Medicaid turned on, but to getting usable Medicaid turned on so that the person can actually access the medications that they're going to need, as well as the therapies that they're going to need, and the providers that they're going to need, and the providers will get reimbursed for their services. And that takes coordination amongst many offices and thinking about how you work with your local Medicaid office, what can be automated. You know, the Department of Defense is doing a lot of work automating data to find out who's had a history of military service, so then that you can get them their military, their VA benefits more quickly rather than relying on self-report. A lot of systems are now talking about how do we automate data across corrections and Medicaid so we don't have to have somebody turning a switch and getting this and getting that. So just things to think about. I don't have all the answers. I'm raising questions of things that have come up in my work about some of the challenges. What IDs do people need to facilitate access to care? Again, what are the partnerships? Who are the natural alliances in the community for those reentries? How do we think about peer support? Is that covered by your Medicaid service? And the like. And then, of course, naloxone education and naloxone distribution upon release. And then, okay, this is finally the last side. Participation with parole in programs is really important. How does parole work, or probation, because a lot of people are coming out of corrections on probation, so depending on which system your people are coming out of, how do they work with their local providers? Again, because we know that people are high likelihood of recidivism in this population, where does the risk-need responsivity paradigm fit in? How do you cross-train? Again, case conferences are a great opportunity, both with good outcomes and bad outcomes, to take your lessons learned and see where your dots weren't quite connected and where you can do better. And then also crisis planning. That's a big part. It's a big part thinking about suicide management nowadays. Who are the points of contact? How do you think about a crisis? And then, what's your system when there are bad outcomes? Just like when hospitals discharge people and there's a bad outcome within 30 days, there should be a mechanism. Most correctional facilities look at what happens within the walls, but there should be a mechanism to think about morbidity and mortality reviews even 30 days upon release to understand what could have been done better and for quality improvement. So that's where I'm going to stop. I'm going to turn this over to my colleague who's going to introduce himself. He'll talk more specifically about the medications.
Hi, my name's Tom Lincoln. I'm a primary care provider and work at Community Health Center and the Hampden County Corrections in Western Massachusetts. And the idea here is to kind of focus on the medications. I'm going to come at it as a primarily medication treater. I've been doing MAT treatment with buprenorphine going way back, and what's new for us lately in the past year is adding on methadone in our program. So, and we have women in the facility, so we've got methadone experience going back many years in the setting of pregnancy. So a little bit more of a deeper dive from this morning into just kind of a little bit of nuts and bolts of the medication that hopefully you might find useful, and particularly have some time for questions to be able to discuss aspects of the medications that you have questions on from this morning. So I've got more slides than we're actually going to focus on. I'm going to jump over a few of these. Some of these are in here. We can come back. If anything intrigues you and you want to ask about it, please feel free to just grab me if I've flipped by it and it's something you want to know. We've already covered the high mortality, particularly the target date when folks are getting out in the first week, the first month. This, actually surprised this slide hasn't come up before. This is the Rhode Island data that showed as the program was implemented in the Rhode Island Department of Corrections for the first 6 months of 2016 compared to 2017. Between that period, there was a vast expansion in it. And looking at the statewide data on overdose, this is some of the population-based data that's demonstrating decrease in mortality. This is primarily methadone and buprenorphine that have been expanded. You're seeing a 65% reduction in overdoses in folks that were incarcerated within the past year within the state. So the entire mortality within the state dropped, but particularly in that population that was incarcerated within the past year. And if you look even finer, and this doesn't get talked about as the big number there, but if you look at folks that were incarcerated within the last month, you actually see going down from 10 to 1 overdose. So it's pretty striking. There's not other things going on in the state that really can explain these sorts of numbers, and you're seeing it concentrated in the population that was corrected, that was in corrections. Population that was corrected. That would be nice, the population that was in corrections that got corrected. There we go. So that's just one tidbit. For overdose, really the studies that see a decrease in overdose are population-based because the controlled, smaller studies, the randomized controlled trials, those sorts of things, they're really not powered for seeing a decrease in overdose. So when we're talking about mortality reduction, initially we're talking about population-based studies. But the smaller studies, which I'm not going to show you a lot of, but we do see benefits with the medications for opioid use disorder in terms of continuity of care, substance use, functioning, role functioning, sorts of things, and in some cases recidivism as well. So we're talking about the 3 medications, methadone, buprenorphine, and naltrexone. Does anybody want to run through agonist, partial agonist, and antagonist, blocker? Are folks familiar? Okay. So methadone, a few things to highlight in it. As you know, it's only in certified opioid treatment programs unless it's in a clinic, hospital sort of setting, so many facilities actually have that license. So if you're treating something else, which pregnancy would fall under that, there's the ability to use methadone without being an opioid treatment program. But other than that, only an opioid treatment program. Its half-life, decay is 15 to 60 hours, so long-acting. But you got this big variation here. So a variety of metabolism differences. So it's going to last much longer in some people than in others. And so some of the questions that come up in terms of some of the dosing or how quickly we can adjust stuff or what the right dose is, the variation here makes this tricky. It has, since it's a full agonist, you can overdose with it. You can stop breathing if you go up high enough on it. And it has a number of interactions and particular things you need to be aware of in terms of medication interactives with a lot of psychiatric medicines, for example. So it's a Schedule II, like morphine. So if it's being used outside of the treatment for addiction, it can be prescribed for pain, for example. And that's, it in the community setting where most of the overdoses of methadone have happened. It's been when it's been prescribed for pain. So when it's prescribed in the way that it's prescribed in an opioid treatment program, a much more cautious and gradual approach, then it ends up being prescribed with pain and controlled. So not sending somebody home with a month's worth of methadone pills. So it's in pain management where we've really seen the methadone overdoses, and particularly with diverted methadone, which comes primarily out of pain management. So very dangerous. And we'll come back in a second to why it ends up being so dangerous for overdose. The cardiac, in some settings, depending on medication somebody is on and the dose of methadone, there's EKGs that need to be checked. And you have to very much look at what other medications somebody else is on, much more so than buprenorphine. So this is an example of the time course of methadone building up as it gets dosed. So we figure a medication as it decays with its half-life, that's how long it takes to reach half the concentration from the peak. As you're getting to steady state and giving somebody doses on a daily basis, to reach steady state, it takes about 4 or 5 half-lives. So depending on the person and how fast their metabolism, the level is going to be building up. The dose you took yesterday is going to hang around. The dose from 2 days ago, it's going to hang around a little less. So by the time somebody is out 2 or 3 days, their level of methadone is much higher than that initial dose when you gave it. So we start on a low dose, start low, and go slow, which can be difficult if somebody is withdrawing. So you have to have titration over that initial day to match what the withdrawal is. And day 2, you have to match what the withdrawal is and then be worried about the dose building up over time. So if somebody has missed several doses of methadone, that levels drop back down, which often happens in corrections. So it's pretty classic for folks to have relapsed. That's what led them to get arrested. That brings them back in, and they were several days without methadone. If somebody misses 3 days, 4 days of dosing, then you might have to start over or adjust the dose. And there's various kind of general algorithms and approaches, but it's an individualized practice, so you need to take other things into account as well. Any questions? Is this relevant? Is this okay? Just one example. This is also Rhode Island. This is the study where folks are randomized either to be on taper down off of methadone or stay on methadone over the course of months. And this is folks comparing in blue there, folks who stayed on methadone, and these are folks who were supposed to taper off. Many of them didn't finish tapering off. So if you look down here, this is kind of the big comparison. This is looking at 30 days after incarceration and how many people stayed within treatment. And you can see folks that left the facility on methadone essentially entirely continued into methadone within the first 30 days. And folks that left off of methadone, much, much lower percent. This is 50% range here. So a dramatic difference with continuity of care. So that's an excellent example. Another example out of Baltimore, I'm not going to go through the details, but did not see the numbers, and we'll actually come back to what the numbers were. But this was a randomized controlled trial also. Saw differences as well. Saw benefit in continuity of care. I won't go through this in detail, but was not really to the same dramatic difference that was seen. Buprenorphine, not around as long. In terms of studies, and methadone in correction studies go back to the 60s. So buprenorphine, partial agonist, requires the X waiver. Half-life, also long, which is, again, the benefit of it. available in the daily format for the sublingual that we talked about. This morning we talked about the injectable forms as well. Because it has the sealing, it's much, much, much less likely to cause cessation of respiration. So to overdose on buprenorphine by itself is extremely difficult, seen in the pediatric population, seen with mixing with other medications. But in terms of that fine titration that needs to be done, much more forgiving and easier to use medication in managing withdrawal, and particularly with getting somebody stable for treatment for long-term treatment of opioid use disorder. Did folks hear the question about folks getting high on Suboxone and it wasn't supposed to be that way, and why is it, the number one medication being smuggled in? So I think a lot of it being smuggled in is for maintenance too. So it's untreated opioid addiction folks are trying to maintain, and it's very potent. So even very low doses can maintain long half-life. But for somebody who is opioid sensitive and does not have a tolerance, if you take buprenorphine, Suboxone, and it's used for pain at much lower doses as well, it has the regular old opioid effect. So when you're not used to an opioid and you use buprenorphine, it feels like morphine or other opioids. So it's absolutely the case that you get the euphoria, and once you've been on it a while, you do not feel that. So that does not last, and then it's maintaining like with other opioids. The area where buprenorphine gets to be trickier is, or one aspect where it is trickier than methadone, is when you're treating withdrawal. So with buprenorphine, because it has this sealing effect, you're going to have the mu receptor, the opioid receptor, locked right in the middle when you get enough buprenorphine on board. If somebody has fentanyl, heroin, morphine, and levels that are high enough, methadone, and you give them buprenorphine right away, it's going to displace that and bring somebody down to a lower level of opioid effect, and they're going to go rapidly down, and that's going to be a withdrawal. That will manifest as withdrawal. So if somebody comes in and they are not far enough in withdrawal and you give them buprenorphine, trying to treat their withdrawal, you're actually going to make the withdrawal worse. So that's precipitated withdrawal. And it's the exact same thing as if somebody came in and you gave naloxone, Narcan, on whether they're on buprenorphine or any other opioid, precipitating withdrawal. You're bringing them from a higher down to a lower level. So it does become tricky in that, and particularly with long-acting. So when somebody comes into a facility, and say it's a facility where you're trying to use buprenorphine, you don't have methadone, they come in on methadone, they go into withdrawal on the methadone, even a day, 2 days, 3 days, sometimes you give buprenorphine to try and treat that withdrawal. It's not far enough along. They're still up here, and you precipitate withdrawal. So that's one of the ways in which buprenorphine is not a great substitute for having methadone within a facility. So that's one of the settings. So if folks come in on methadone, switching over is not a trivial endeavor. The absorption, I guess we won't spend a lot of time talking about the absorption and the lines, and then diversion, because you got some time to focus more on that practice. Just to mention the naloxone that's in the formulations, such as Suboxone, which has buprenorphine plus naloxone. The naloxone really does not have any effect unless it's injected or snorted. It's not absorbed sublingually. So the reason that buprenorphine behaves the way it does has nothing to do with the naloxone in there. Naltrexone, the third medication, we talked about this morning as well. A full blocker, the oral form exists daily, but has not been shown to have benefit really for use in opioid disorder, primarily used for alcohol. The extended release naltrexone, Vivitrol, is the form that's used for opioid use disorder. So the experience, I'm sure many facilities have been using this who are in the room familiar with this. Because it's a blocker, it's not scheduled, it can be prescribed by anyone with a prescribing license, does not need an X waiver, does not need to be an opioid treatment program, but much less data on this overall, and certainly less data in terms of corrections. Does not have the population-based mortality benefit that's been seen with the agonist therapies. Does have evidence of improved engagement in care, particularly as compared with not using any medication at all. But as was mentioned this morning, people do not tend to stick with it long. Because it's just a blocker, there's no withdrawal from the naltrexone. So the nice thing about it, if somebody wants to just be on treatment for a short term, which for many people is not the ideal, but if somebody just wants to be on treatment for several months, it's not going to be difficult to stop. So it's a double-edged sword. The good thing is it's easy to stop. The bad thing is it's easy to stop. Overall, in our facility, it's been fairly popular because we've had it around for a long time. So it's kind of settling out probably in 10% maybe of folks in terms of the medications for opioid use disorder. But it's expected to be a smaller component of the medication therapy. And it's particularly as compared to somebody who's not interested in being on any other medication. Let's skip to this. So this is the main community trial that compared buprenorphine with the extended release naltrexone. So this was folks, and the difficult thing you can see here is getting folks on the naltrexone, which is less an issue that we've had in corrections if folks have been in there a while and they've come off of all the opioids. If you're starting something before somebody is leaving, you might see things to be more equivalent. But one of the big things about this trial, which did say, take-home message is that it's a treatment that's in the ballpark, naltrexone versus buprenorphine. This was a trial where folks were interested in being on either of the medications. Most of the folks that we're seeing are interested in the opioid therapy. So offering the naltrexone when really somebody has the experience and the interest in a agonist, I don't think makes that much sense.
Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorder. To request technical assistance, visit opioidresponsenetwork.org.